frame our discussion today, it is my absolute great pleasure to introduce Professor Dame Sue Hill, Chief Scientific Officer for England at NHS England. Sue is the Senior Responsible Officer for Genomics in NHS England and is responsible for overseeing the implementation at NHS of the Genomic Medicine Service. She has been a vocal advocate and a true international leader in the clinical implementation of genomics. As many of you know, the UK is a world leader in genomics, and the unique structure of the NHS is allowing England to deliver these advances at a remarkable scale and a pace that is unique and focusing on patient benefits. In September 2020, the UK unveiled its new national genomic health strategy, Genome UK, the future of healthcare, focusing on 3 areas. And those areas were diagnosis and personalized medicine, prevention, and research. This strategy is also now aligning with the new UK Life Science Strategy released in July 2021. Professor Dame Sue Hill leadership in genomics has been key to ensure the transition from a research-based initiative at Genomics England into a clinical implementation at the National Health System. So my pleasure to welcome you, Sue, here today, and we're very much looking forward to hearing your presentation.
Thank you very much, Catalina, for that absolutely fantastic introduction, and I'm really delighted to be here at this Genome Canada event, and I'm really delighted to hear about the inclusivity and the diversity of discussion that you will be having later on today. Unfortunately, I'm not going to be able to join in those roundtables, but I think it's just the type of conversation that we need to have, and it's really important that we're always reflective of the populations that we serve wherever we are. So I'm going to set out in this talk about the genomic strategy within the UK, and some of it will be England only, and then very specifically about the implementation of genomics in the National Health Service in England that I have a specific responsibility for. What I won't be talking about tonight, but is I've had a fantastic and fascinating time over the last 18 months leading part of our pandemic response, particularly in emerging technologies in validation, regulatory compliance, but specifically co-directing our viral sequencing program. But we can touch on that in questions. And there's no doubt about it that the population in the UK now know more about molecular diagnostics than they've ever done. They understand the importance of variants of the virus in terms of potential evasion of our host response systems, and they can use really simplified molecular diagnostics within their home in the form of lateral flow devices and make their own diagnostic decisions. So let's just start and move on to my next slide, which is I'm going to start with how we've developed our strategy and what the approach is. And my next slide just sets out that over the past decade, there's been a real history of political and strategic commitments in genomics. But I want to say it's been much longer than a decade. It goes back to the decade before, and indeed many decades before that, at the very start of the National Health Service in the UK, in terms of understanding the importance that genetics originally would play. But over the last 10 years, there's been an acceleration in terms of both the political commitment to genomics, and then the development of subsequent strategy to realise those governmental ambitions. And at the bottom, it just sets out some of the key commitments. In Genome UK, it set out, and this was originally in the industry strategy, that in the UK we would undertake 1 million whole genome sequences by 2025 at the latest, 500,000 of those to be done in UK Biobank, on 500,000 participants in that study, and 500,000 within the National Health Service that I'll come back to. But there's also been major investment in the 100,000 Genomes Project, in other testing, and through the NHS funding, which it gets from central government in our investment in the Genomic Medicine Service infrastructure I'm going to talk about. What is being established under something called Our Future Health, which is a 5 million early detection cohort that will also focus on genomics, and particularly predictive and preventative genomics. And then, of course, we've had a major investment, not only in increasing our viral sequencing capacity, but also in response to the pandemic, but also in terms of a number of different COVID-related research studies, including genomic, which is actually helping us to understand the host factors at a genomic level that might predispose individuals to developing severe or moderate disease, leading to them to be hospitalised. And there's ongoing commitment in terms of two other projects, such as newborn sequencing, such as extending the type of genomic investigations we will do in cancer. So we adopt a more multimodality approach to genomic technologies that are applied in a similar way that we do to imaging. And then also coming back to ensuring that the research database that we have are reflective of the diversity and the rich diversity of our population in the UK. So if I go to my next slide just sets out that this is enabled by a real ecosystem. At the one end on data and digital, with a number of different organisations, with research and innovation through Genomics England that was established as an arm's length body from central government, but still with Secretary of State as a single shareholder, so that can go and really set up a raft of different things without the constraints of government or indeed the NHS, but also linked to our National Institute of Health Research, and also something called UK Research and Innovation, which funds all of our funding bodies like the MRC and Wellcome in the UK. But then we also have strategy and policy that's coordinated by the government, both through the Department of Health and Social Care and the Office for Life Sciences. And part of that has been the setting of a 10-year life sciences strategy for the sector, as Catalina referred to earlier. And then in NHS England Improvement, we set the overall strategy and commission services, and those are delivered through providers and our integrated care systems. And then we have a number of different elements that help us in terms of our workforce development, including Health Education England. So it is an ecosystem, and an ecosystem that comes together. And I'm going to come back to how it comes together, because coordination and enablement is the most important part to making this work. My next slide just sets out, which we all know, is that there are a number of different challenges for healthcare systems as we look towards the next 10, 15, 20 and more years ahead of us, including, for example, our ageing population living with comorbid conditions and the increased rates of non-communicable diseases such as cancer. And part of what we want to do is ensure we deliver equity of access and high quality care for all. And so we know in healthcare systems, it will require a balance between population health on the one side. So how can we be on the front foot in terms of earlier diagnosis of disease or predictive prevention, and where we might intervene with lifestyle choices, but on the right-hand side, much more personalised care. So moving towards value-based healthcare, driven by data, including the ways in which we use our drugs within our healthcare systems that cost us an increasing amount of money each year, especially in publicly funded systems. So my next slide just sets out that genomics plays a key part in responding to those healthcare challenges, those healthcare system challenges, because it can enable preventative approaches through identifying predisposition markers such as for inherited cancer, like for the BRCA genes, or for example, the genes associated with something called Lynch syndrome that leads to people developing colorectal cancer, and that often happens through families. It can lead us, enable us to make much earlier and more comprehensive diagnoses, so we can treat earlier and get better outcomes. Making that more precise diagnosis enables us to segment different populations, all within the umbrella title of a particular condition that might enable us to treat different groups differently depending on their genomic profile. It enables us to make more effective treatments with much fewer adverse drug reactions and increase the eligibility for clinical trials, particularly those that have genomic targets. But also this enables us to work with industry in a new way to ensure that we're able to enable clinical trials, especially for people who have within a very given condition where there might only be very small numbers, and therefore drug discovery is very expensive, and it's very expensive to fund clinical trials for those. Now, importantly, in the NHS and in the UK health system through the government, we've also used genomics to align with all of our disease-specific strategies, whether it's rare disease, whether it's the ambitions for cancer and improving the number of people who survive or who are diagnosed at an earlier stage, in terms of improving our cardiovascular strategy, but also linked to the NHS England improving outcomes through personalised medicine to tackle our rising drugs bill, which at the moment is over £17 billion and rising, such that we use more precise and effective treatments and reduce our adverse reactions that account for 1 in 15 hospital episodes. If I can go to my next slide just sets out that this is all encompassed within the Genome UK strategy that I was part of creating. Its vision is to create the most advanced genomic healthcare ecosystem in the world, and I spoke about the ecosystem earlier, so it's bringing all those different elements together. But for the first time, it's very much aligned with the healthcare system, with 3 cross-cutting themes of diagnosis and personalised medicine, on prevention, that predictive prevention I've already spoken about, and then on the alignment with research to support this seamless interface between research insights and then healthcare delivery. And I'm going to come back to that again. You'll see that there are a number of different cross-cutting areas. So these are themes, sorry, and I didn't say that earlier, and these are the cross-cutting elements. And you can see that includes ongoing dialogue with the public and with patients, workforce development, and really supporting our industrial partners, as well as all the work we need to do to develop nationally coordinated approaches to data and analytics. And this is truly a full country endeavour with an implementation group that I actually co-chair. If I could go to my next slide just sets out some of the ambitions. And so it sets out under diagnosis and personalised medicine that 1 million genomes that we're going to sequence, both from the NHS and also from UK Biobank. How we explore next generation approaches for cancer that I mentioned earlier, but also how we can sequence more pathogens to help us not only control outbreaks, help to better monitor and track and respond to any emerging pandemics, and to continue with the fight on antimicrobial resistance. On the prevention side, to really develop public health and screening to use genomics, and to understand how we can position polygenic risk scores and better use genomic testing in reproductive medicine to support informed choices. And then on the research side, it's trying to bring together all of the national data resources with genomic and other data that might be phenotypic data drawn from longitudinal health records, so that it's available for all rather than for small little pockets of for example, academic. But part of this is making sure that we do research at scale. But as I said earlier, we've got greater diversity within the reference genomes that we use to align any of our whole genome sequencing. And there's a number, as you can see, of workforce developments across the multi-professional team. But importantly, around data, establishing standards for genomic and health data, and using that federated access to data that I mentioned earlier for research use to enable comparisons across different data sets. And that, I have to say, I'm pleased is now making progress. It's taking some time to think about the solutions for a federated access database. If I can go to my next slide now is just my segue into strategy implementation in the NHS. And if I can go to my next slide, this just sets out the NHS long-term plan that was published before Genome UK, and it set out a number of ambitions for the healthcare system, as you can see at the top of this slide. And some of it comes back to what I've said already about the challenges for the healthcare system. How do we tackle, the aging population do we have? How do we tackle health inequalities? How do we give people the best start in life, but deliver world-class care, but also how that happens and is delivered in providing value for taxpayers. And you may have heard there's a new payment that all citizens in the UK will have to make following further investments in the NHS in England, in particular, to tackle restoration and recovery of services, and particularly our long waiting times. But there are a number of different genomics commitments that I've summarised on the bottom of this slide. That whole genome sequencing commitment, so our targeted investment in innovation, our approach to children and young people so that all children with cancer are offered whole genome sequencing, so sequencing of those 3.2 billion letters in our genetic code, and also sequencing seriously ill children, in extending our access to molecular diagnostics in cancer, in linking and correlating genomic and clinical data and patient data to deliver our commitments around research, and to tackle those improvements we need to make in cardiovascular disease by expanding access to genomic testing for familial hypercholesterolemia, that condition that causes individuals to have high levels of circulating fats in their blood, with poor outcomes for some, and often undiagnosed until something catastrophic happens. So my next slide just sets out in terms of the strength of the NHS to deliver this. And we can deliver it because we work at a whole system level. We have longitudinal health records, and if individuals give their informed consent, then data can be pulled from both their primary and secondary care data across their life course. And we've got, because we can work at a whole system level in an integrated national system, we can adopt at scale. Now, what we've done to drive forward our genomics commitments is we've established a genomics unit, and you can see the different elements of that genomics unit in the left-hand side. And it's part of NHS specialised commissioning services. And these are services that we nationally commission, which secures standardisation, and it means that we can monitor equity of access across the country. The genomics unit in particular commissions and contract services. It leads and is data informs performance management. We make national investment and business planning decisions, and we set policy strategy, and that is inclusive of operational policies. We're able through this process to provide direction through mandating an approach, and we can hold the system to account. We can link to those broader system priorities I spoke about earlier, like cancer or rare disease. And we can also link it with our approach to medicines optimizations and medicines access. We can adopt new technologies at pace because we can align it with our commissioning and contracting. And then we can undertake collaborative working with a range of partners, including industry, that's been further strengthened by our experience in the pandemic. So that's why we have the strength to do what it is we actually do. If I can go to my next slide. My next slide sets out what was really important to us in establishing the fundamental change that I'll talk about, was a proof of concept study. If I can go to my next slide, and this was the 100,000 Genomes Project. And in or around 2012, Sir John Bell had already said the NHS needs to develop tools and expertise needed to take advantage of a revolution in genetic testing. So this was about needing to fundamentally change what was already in place. In 2012, as part of an Olympic legacy announcement, the Prime Minister announced the 100,000 Genomes Project to sequence 100,000 genomes from people with rare disease and cancer, and the investment to go alongside that, but not the investment for the NHS to contribute, which I'll come back to, but for the sequencing, for the analytics, for the research environment. And Genomics England, so this is the company with a single shareholder, Secretary of State, so they're free of some of the constraints that there are from being a government department, or indeed within the NHS. They were announced in July 2013. If I can go to my next slide. My next slide just outlines, this was the strategic approach to this project. On the right-hand side, the NHS contribution, and you can see from consenting individuals to collecting samples, to eventually validating, reporting, and then returning of results. And the NHS England, so not Genomics England, NHS England invested in creating 13 NHS genomic medicine centres to do this, and to work across their providers within their patch. And by providers, I mean hospital organisations that were within the geography that the 13 NHS genomic centres serve. So that was between 5 million population and 10 million, depending on where they were. On the right-hand side, Genomics England established a biorepository for samples, established a contract with Illumina for sequencing, and created this informatics architecture that's essentially a trusted research environment for access in the form of a reading library rather than a lending library for industry users and scientific and clinical users. And you can see from this informatics infrastructure and the bioinformatic pipeline for the analysis of whole genome sequencing, this was what enabled feedback to the NHS. So the whole approach for this proof of concept was to make the UK a world leader in whole genome sequencing, to advance genomic knowledge and turn that into healthcare interventions, but at the same time understand how the workforce needed to be developed. And at the bottom there, what we created in NHS England was an innovation pipeline. So we created the direction for implementation. They led the transformation, and they built the readiness for the future. And just these are recent figures. We have now over 107,000 genomes in the research environment, the majority of those in rare disease. And overall, over 122,000 samples were collected by the NHS for this proof of concept study. Not all of those, as you can know, were in the research environment. So it said how we could do and introduce whole genome sequencing, how we could establish and align research, and how we could feed back insights into healthcare interventions. So an important proof of concept study. If I go to my next slide just sets out, these were the key findings. We had an overall 20% diagnostic yield or diagnosis, but some of them were much higher, 55% in a particular type of kidney disease, and another one in a particular type of bone development rare disease condition. But on this basis, I was able to make, because this was over and above standard of care, in understanding where whole genome sequences fitted in our diagnostic strategy, I was able to make the case for introducing it. In 24 cancer types, we had a 50% known actionable or potentially actionable gene identified. There's still more work to be done because whole genome sequencing continue to give, and that includes feeding back additional look for findings to participants who took place. And that's, for example, not looking as well for other genomic variants that might exist in individuals that, for example, might predispose them to having to developing cancer because they have an inherited cancer gene within their genome. So if I could go to my next slide, the next slide was, what do we do with all of this? So this is our NHS Genomic Medicine Service. If I can go to my next slide, what we did is we looked at all the elements of the system that needed transforming, building upon the 100,000 Genomes Project, so looking at whole genome sequencing, but then looking at all of our genomic testing through the infrastructure we had. We knew we had variation in access, and so we needed to look at a national commissioning model and secure funding for that infrastructure and establishing standards and specification. We had a dispersed infrastructure, and so we consolidated it, and we standardized clinical pathways and embedded workforce education and training. We had a lack of performance data, so we've established performance monitoring to benchmark between laboratories to monitor access and inform our future approach. We had clinical leadership concentrated in clinical genetics, but we knew we had to develop the broader multidisciplinary team. We needed to embed innovation and new technologies, building upon the lessons we'd learned in the 100,000 Genomes project. And we needed an infrastructure that would support future technologies. And we had a lack of IT connectivity that meant we've had to develop NHS informatics and the data infrastructure and bring together multiple systems to collate and curate data for individuals, as well as using different ways of actually characterizing individuals, particularly, for example, using something called HPO terms to characterize people with rare disease. If I can go to my next slide just summarizes our NHS Genomic Medicine Service that we launched in 2018. It's built on a number of key principles that I've already said and outlined, and you can read on this slide. It summarizes that NHS England and Improvement commissions and funds the service and is responsible for national oversight. We've created 7 NHS Genomic Medicine Service alliances responsible for multidisciplinary clinical leadership to embed genomic medicine. And we continue to collaborate with Health Education England to support workforce development. At the core is 7 NHS genomic laboratory hubs who perform the testing, analysis and interpretation. That's informed by a mandated National Genomic Test Directory, covering the full repertoire of testing from single genes to whole genome sequencing. We have whole genome sequencing provision and bioinformatic analysis of that whole genome sequencing provided in a partnership and a contractual partnership with Genomics England. And when individuals provide their informed consent, the data at the moment just from their whole genome sequence enters into the National Genomic Research Library, annotated and curated by Genomics England to enable ongoing research. And we have multidisciplinary teams. If I can go to my next slide just sets out within this structure, we deliver the full breadth of genomic testing and the continuum, whether it's disease focus, population-based, or is horizon scanning. It covers targeted testing for particular causes of genetic disease. It has panel testing, either small or really extensive next generation sequencing, for example, 500 gene panels for cancer testing. In a pan-cancer, so covering all cancers, whether they're solid tumours, so on one panel, or hematological blood-borne tumours in another. We have exome sequencing that looks at all of the genes within the genome, rather than the whole of those 3.2 billion letters that we do through whole genome sequencing. We have national services for seriously ill children and babies, and for fetal testing to inform what is happening sort of in utero, in the womb of women who are carrying babies. And we have a plan now to extend our whole genome sequencing from where we are now with a small number of rare diseases and a small number of cancers to much greater numbers of conditions. We have core testing delivered by all 7 genomic laboratory hubs, specialist testing by between 2 and 5, and national provision for that exome sequencing and the whole genome sequencing. I can go to my next slide. My next slide just summarizes that this is how we develop our testing strategy. We've got a strategy to move from single gene testing to more comprehensive. And this is through thorough review of scientific and clinical evidence. In the evidence, we look at both the clinical assessment of that evidence, but also the operational assessment. And that includes the cost and affordability and what it would require for commissioning. And then there's the investment and oversight around the mandated use and monitoring whether it is being used, and that we align our commissioning system with this. This test directory is updated annually, and we open a call for evidence to review. But this is just an example on the right-hand side of how we're using whole genome sequencing in kidney disease, where we know it's very difficult to look at particular genes that are associated with polycystic kidney disease that might lead to renal failure. And we made lots of diagnoses of this disease in the 100,000 Genomes Project. So we made a case for inclusion in the National Genomic Test Directory. And this is really important because it can be linked with new treatments such as tavapadon, which slows the progression. If I can go to my next slide. My next slide.
I think it's working. And just a 5-minute warning for the...
Okay, that we've got governance and leadership within this approach, which I won't talk us through at the moment. If I go to my next slide. My next slide just sets out those genomic medicine service alliances have to work with the NHS system within their geography, provide clinical leadership, deliver transformation and workforce development. So that's wrap around. If I can go to my next slide, I'm just going to run through. This is an example, and you can look at this at the complexity of the governance processes. And North Thames have a population of 5 million. And this is what they've put in place to enable that infrastructure that I've talked about and the delivery of those outcomes. If I can go to my next slide, this is just an example of their overall Genomic Medicine Service Alliance Board and how this brings together all of the and creates a regional, a super regional working at 5 million population, clinical and scientific directorate. And NHS England has funded this core infrastructure to really drive the change. If I can go to my next slide. The next slide is around research driving clinical improvements. And this is really what I talked about earlier. And what we're trying to do with our genomic medicine service now is to align healthcare with research, as we did in the 100,000 Genomes Project, to support discovery, translation, adoption, and spread, and use research insights to evolve genomic healthcare, provide data from genomic healthcare to accelerate research. And you can see on the left-hand side, doing this, we found in the 100,000 Genomes Project, we could improve the type of diagnostics discovery that is made because of the link with academics who could do all the more complicated studies to determine whether a particular variant was pathogenic. On the right-hand side, within the 100,000 Genomes Project, there are all these benefits from accelerating genomic research. At the middle now, we've created an NHS Genomic Medicine Service Research Collaborative. I can go to my next slide, and I'm going to have to go very quickly now. This just outlines the research collaborative with a number of different goals, including how we support further development of genomic medicine and support genomic research. So it's done in a coordinated way across those 7 genomic medicine service alliances, with a number of benefits in terms of delivering research at scale and speed, but better coordination of research, and also better support to industry, to academics. And we're aligned with this is the capacity and capability monitoring, and understanding what is already being supported in the system, but how we can support industry to access and reach into the NHS, reach into patient cohorts quickly, but to do this within a governance system that maintains the integrity of both the system and for the individual. If I can go to my next slide. My next slide just shows that the importance within that system I've just talked about using real world evidence to really understand the type of technologies that we're bringing into the system and how that we actually can do that in responsive and adaptive pathways that lead to commissioning and contracting of those genomic technologies. If I can go to my next slide. My next slide just sets out, and I'm not going to talk through this. This is all the things that we've delivered through the Genomic Medicine Service to date, and even through COVID-19. And you can see that we perform over 600,000 genomic tests each year. But this just summarises also that from NHS England and Improvement, we're funding 7 national genomic transformation projects and 26 local genomic transformation projects in those 7 what we call GMSAs, linked to more local needs. And we funded 200 posts in the Genomic Medicine Service Alliances to support multi-professional clinical leadership, and over 2,000 NHS staff who are dedicated in general to the delivery of this system. I can go to my next slide. My next slide just says genomics is a global initiative, and we're really delighted to be part of the Global Alliance for Genomics and Health, and particularly for the Global Genomic Medicine Collaborative. And me and my team work very closely with Catalina on the policy and strategy approach on this, but we're delighted to be working with Canada, and there's no doubt about it, we have to collaborate if we want the best outcomes for our patients and our population. If I can go to my next slide. My next slide just, and I haven't got time to talk about this in any detail, these are some of the challenges we still need to think about wherever we are in the world. We've got to retain and build public trust within a societal contract. We've got to work within an ethical framework and answer some of the big questions about when to carry out whole genome sequences within the life course. And we have to change pathways of care, and that includes continuing to develop our workforce. If I can go to my next slide. These are the themes for success. There needs to be government and senior healthcare leadership interest. There's proof of concept studies enables the evidence to lead to an investment in the infrastructure that needs to be co-designed. There needs to be a receiver pull, and then the right alignment with clinical and professional leaders. And there needs to be the user pull with the ongoing co-creation through public dialogue. And if I can go, and I know this is my last slide. My last slide just sets out, when you get it right, it is so fantastic. And this was Lee Morris, who had a rare inherited retinal disease. And through the decisions we made in NHS England and specialised commissioning to support gene therapy, doctors saved his sight and enabled him to see again. So with that, I want to thank you very much for listening to me this evening, and I hope that's been helpful in terms of setting the scene for today. Thank you.